values, but uh, we exactly don't know how to interpret these values. So, in the series today with us, none other than Dr. Sudhir Mehta, sir. He is the pro chancellor at NIMS Medical College, and he is this director and medicine department NIMS. So, over to you, sir.
Yeah, thank you, Dr. Daria. Very good afternoon to all of you. Uh, Today, as it's raining heavily in Jaipur, I don't know in which other part of the country the pre-monsoon have arrived. I
It's
think
raining, sir.
yeah, it's raining heavily. My slides are visible.
Yes, sir. It's visible.
Is it moving?
You just put it on this slide show, sir.
Okay, it's there. I have already done it. Is it moving or not?
No, 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 no. It's not moving, sir.
It's already on the slideshow.
But it's not moving, sir.
Not moving. Uh, Let me do one thing. Anand, can you help me out? It's
आनंद,
already.
जी सर।
I have
सर का
already.
स्लाइड मूव नहीं कर रहा।
सर स्लाइड मोड सर खुद से करेंगे वहीं से।
है।
सर वापस बैक जाके दोबारा से ले हो सर इसको।
हाँ, वही कर रहा हूँ मैं। अ,
सर ऊपर में एक ऑप्शन है सर, स्लाइड शो।
हाँ, स्लाइड।
हाँ
शेयर
सर।
शेयर। नहीं,
हाँ
स्लाइड
यस
नहीं।
सर।
व्हाट
स्लाइड
इज?
शो में सर जाके।
एक मिनट, ऊपर कहाँ है? ऊपर नहीं आ रहा स्लाइड में, वो शेयर आ रहा है केवल।
ऊपर भी है सर, नीचे भी है, आप दोनों में से कहीं से भी कर सकते हैं।
हाँ, वो तो। अ, एक मिनट। शेयर है, शेयर। हाँ। ओके, आई एम शेयरिंग। ये तो ऑलरेडी मेरे शेयर चल रहा है ना। हम्म।
बट इट्स नॉट मूविंग सर। आप पूरा कट करके वापस बैक चले जाइए सर।
हाँ, वही करना पड़ेगा। इट इज विजिबल नाउ।
हाँ यस, नाउ इट्स विजिबल। पर स्लाइड मूव करके देखें सर।
हाँ, ये स्लाइड शो करता हूँ पहले। स्लाइड शो हो गया। नाउ इट्स मूविंग।
नहीं सर,
स्लाइड शो में गड़बड़ हो जाता है।
स्लाइड शो हो ही नहीं रहा सर, अभी भी वही वाला जो है।
नहीं, मेरे अच्छा, ओके।
हाँ इसमें नहीं।
ठीक है, हो गया। हाँ, अभी विजिबल नहीं है।
नहीं सर, या तो आप भेज दीजिए, आनंद को भेज देते, आनंद वहां से कर लेगा।
हाँ, मैं आनंद को व्हाट्सएप करता हूँ।
हाँ
आनंद का कौन सा, इसी में डाल देता हूँ मैं।
सर मैं भी मोबाइल से ही लॉगिन किया हूँ सर, लैपटॉप तो मेरे पास अभी
अच्छा
है नहीं, मैं आउट ऑफ पटना हूँ।
अच्छा अच्छा।
ये तुम्हारे TICP शॉर्ट कोर्स में मैंने भेज दिया स्लाइड्स।
नहीं पर वो है नहीं ना सर, वो भी मोबाइल से लॉगिन किया हुआ है।
ओ, मोबाइल।
वो भी आउट ऑफ पटना है।
हम्म।
वो भी अभी स्टेप उस पर ट्यूरिंग पे ही है।
अच्छा अच्छा अच्छा। सो मैं वापस। हाँ,
आप इससे एग्जिट कर जाओ सर, वापस से ज्वाइन कर लो एक बार।
हाँ, वही करना पड़ेगा मेरे को लगता है।
एग्जिट करके फिर रीज्वाइन करो।
नहीं, पूरा नहीं, जूम से या मैं
जूम से एग्जिट कर
अच्छा,
लो सर, एक बार आप वापस से ज्वाइन करो।
नहीं एक बार आ जाएगा मेरे ख्याल से। इवन शेयर भी नहीं है, I will do it. अब आया डॉक्टर दरिया, इज इट विजिबल?
Yes, sir. Yes, sir. Yes, visible,
यस
sir.
सर, नाउ इट्स मूविंग सर।
इट इज नहीं, आई एम नॉट मूविंग, इट इज नॉट मूविंग फ्रॉम माई एंड नाउ। इट इज मूविंग। हेलो,
सर यस सर।
is it moving? But it is not moving from my end now.
Slide not moving, sir.
Hmm? Slides are not moving. Hmm. Stop sharing and again do it.
How it's working sir?
I think my slides is not visible on the screen.
No slide. Just your video, sir.
No, it's visible.
The slides are visible.
Okay. Now, is it moving? No.
No, sir.
Is it moving now?
No, sir. Only first slide is visible here. Click on the second slide, sir. Then it will.
I'm already moving my slide. This is first, this is
Oh, it's
second.
not coming.
Can you help, Anand, just help me out? Share हो गया है, सब हो गया इसमें. Hmm. Now it's visible,
Yes sir, it's visible.
but not moving.
Not moving.
Daria, you just help me out. Hmm. I'll do the slideshow also. Is it moving?
Sir, we can just select on the slide numbers that are present side, sir.
Slide numbers. Yes. What to do?
Sir, after completion of the first slide, on the left side of the screen, can you click on the second slide, sir? It will open, sir.
Now it's open.
Sir, it is opening,
Coming,
sir.
sir. Coming. Yeah.
Third
Second
is
slide.
opening.
Third. Yeah.
Okay, it's opening.
It is opening, sir, third slide.
So now the slide is visible.
Yes, sir, visible, sir.
I will not do the slide share, full slide. I'll just, if it's visible, then I'll continue like this only.
It is visible, sir. You can continue, sir.
Okay, okay. Sorry for the delay. It's just all because of technical problems. And of course, I'm not well versed with all these gadgets. Anyway, my dear attendees and physicians and my friends and colleagues, today I'll be talking on the coagulation cascade testings, which are mainly the prothrombin time and the activated partial thromboplastin time. Now, prothrombin time and partial thromboplastin time, they are the cornerstone tests in the evaluation of coagulation disorders. They offer crucial insight into the integrity of the coagulation cascade and guide the diagnostic as well as the therapeutic approach in a wide range of clinical settings, from unexplained bleeding or events or thrombotic events to perioperative assessment and monitoring of anticoagulation therapy. Now, correlation with clinical context, that is the clinical history and examination findings, bleeding history, medication use, and further tests such as mixing studies, assays of the individual factors, they are very essential for accurate interpretation. For physicians and the PG trainees, mastery of PT and aPTT interpretation enhances the clinical decision-making in hematology, internal medicine, critical care, and as well as in perioperative medicine. A methodological approach ensures timely diagnosis and effective management of coagulation disorders. Now, let us recollect the basic pathophysiology of how a hemostatic plug is formed. Now, as soon as there is an injury to the vessel, the platelets, they adhere to the vessel wall endothelium with the help of von Willebrand factor, which further leads to platelet activation and aggregation, and this forms a primary hemostatic plug. That is known as, the process is known as primary hemostasis. At the same time, the tissue factor, it activates the factor 7, and the whole cascade, coagulation cascade, gets activated and results in the form of fibrin and clot. And this constitutes the secondary hemostasis. Now, this basic understanding of primary and secondary hemostasis is very important to assess and diagnose various bleeding disorders. Now, in the next 40 minutes, I'll be talking on the total coagulation system cascade. What are the pitfalls and how do you interpret and what cautions you should exercise? But very important that whenever we are evaluating a patient of bleeding disorder or doing a perioperative assessment of a patient who is posted for surgery, what should be the components of screening coagulogram? Now, at present, prothrombin time and partial thromboplastin time are the two important tests for assessing the liquidity of the blood, whether the patient has any bleeding disorder or no. Now, very often what we see in many hospitals, and it is very particular among the surgical specialties, that they only order prothrombin time and not aPTT. Now, PT is just, it takes care of one arm of the coagulation cascade, whereas the major, the causes of bleeding disorders which resides in the aPTT arm is often not done by the clinicians or by the surgeons. Now, the concept of clotting time is archived. Nobody uses the clotting time. Again, bleeding time, assessment of bleeding time is outdated because a good history of bleeding diathesis is much more important than doing a bleeding time. Now, let us recall the intrinsic and the extrinsic arm of the coagulation cascade. Now, the intrinsic arm coagulation, it consists of protein 12. It consists of prekallikrein and high molecular weight kinogen, factors 11, 9, and 8. And there's a common pathway of 10, 5, second, and fibrinogen, that is factor 1. This constitutes the intrinsic pathway, and this intrinsic pathway integrity is assessed by the partial thromboplastin time. The extrinsic pathway consists of the tissue factor, which is liberated, that is the tissue thromboplastin, and factor 7. And again, then it combines with the partial thromboplastin time as the common pathway. Now, it's very important that the common pathway, this consists of factor 10, 5, 2, and 1, and it leads to formation of the clot of fibrin. Now, this is basically the hypothesis the coagulation cascade does not work like this inside the body. In fact, this schematic diagram has been made for the better understanding. And this allows us for a practical differential diagnosis of what proteins may be affected based upon the results of series of screening tests. So remember, in vivo inside the body, the two pathways are not discrete. There's a multiple interaction between the two pathways. But this pathway hypothesis has just been made for the sake of understanding and so that we can devise investigations which can clearly tell us which factor is deficient or is there any presence of any inhibitors. Now, prothrombin time and partial thromboplastin time. Now, they are the two important coagulation-based assays. They are sensitive and specific. They are much simpler to perform than doing individual assays for the proteins or the coagulation factors. Now, there are certain bleeding disorders which cannot be detected with prothrombin time and partial thromboplastin time. And these are the four conditions: qualitative platelet disorders, von Willebrand disease to some extent, factor 13 deficiency, that is the fibrin stabilizing factor, and the plasminogen activator inhibitor 1 deficiency. These are the four conditions which cannot be assessed by prothrombin time or PTT. Now, partial thromboplastin time, it is basically what I've told you is a measure of the intrinsic and the common pathway integrity. It measures the time which is taken to form a fibrin clot beginning with activation of factor 12. Now, this is usually referred to as PTT, but actually it is an activated aPTT, what we call aPTT, because it contains the reagent kaolin, which accelerates the rate of the reaction. So appropriately, it is said, it is abbreviated as aPPT with kaolin or aPPT-K. Now, just remember, whenever we are going for the partial thromboplastin time, the plasma should be free of platelet count, and the platelet count should be less than 10,000 cubic mm. And the ratio of blood to the anticoagulant, that is sodium citrate, should be to the order of 9:1. And the tube, it should be collected in the plastic tubes and not in the plain glass tubes or siliconized glass tubes. Now, especially for the partial thromboplastin time, the test should be carried on plasma within 4 hours. If it is not possible, then you should ask the pathologist or the technician to separate plasma from the blood sample, because the platelets get activated and the release of phospholipids. The separated plasma should be defreezed and can be investigated later on. Remember that this test can be interfered by the presence of lipids, high lipids in the, or with the formation, it can lead to what you call the presence of anticoagulants like heparin or oral anticoagulants. So partial thromboplastin time should always be done on a sample which should be on the patient should be in the fasting state. It should not be collected post-meal. And as already told you, it should be collected only in the plastic tubes. Okay, now coming to a condition where the partial thromboplastin time is abnormal, but PT is not normal. Then the disorders which manifest with bleeding include the deficiency of various factors, that is the factor 8, hemophilia A, 9, that is hemophilia B, or 11, which is hemophilia C. So whenever the PTT is prolonged with normal PT and the patient manifests as bleeding disorder, then one should think of the hemophilia A, B, or C. Now, however, very often we see that the patient has abnormal aPTT, but they is not associated with bleeding, and the commonest cause is lupus anticoagulant. This is very often when a physician sees a patient for peri-operative assessment for giving an physician clearance for the major surgery. So the patient has no bleeding disorders, PT is normal, but aPTT is prolonged. One should always think of lupus anticoagulant. This is a very important inhibitor, which can, and usually it is because of the presence of ANA positivity, that is the lupus disease. Other conditions where aPTT is abnormal, but there is no manifestation, bleeding manifestation, that includes factor 12. And the defects in pre-kallikrein and high molecular weight kinogen. Remember, aPTT, if it is prolonged, and these three conditions, that is factor 12 deficiency, deficiency of pre-kallikrein or high molecular, they do not manifest with clinical bleeding. It's very important to understand this. Then the prolonged PTT, what are the clinical conditions? I've already told you the inherited bleeding disorders, hemophilia A, B, and C, and to some extent von Willebrand disease, or because of contamination, or because of use of heparin. Then presence of the lupus anticoagulant, that is the coagulation inhibitor, classically seen in APS antiphospholipid syndrome, or could be the presence of antibodies, especially against factor 8. These are the patients, hemophilic patients with high titers of antibodies against factor 8. Other conditions where aPTT is prolonged includes the DIC, liver disease, and the most important is that the pre-analytical errors. I'll discuss on this important aspect, that these pre-analytical errors can falsely lead to high aPTT values. Now, how do we manage a patient who is on heparin therapy? The test which is most commonly used is the activated partial thromboplastin time. And what we do is we calculate the aPTT ratio, which is the ratio of the patient's aPTT to the aPTT of the control sample. Usually, we keep this ratio between 1.5 to 2.5, and this is the most accepted value. No, it's not that these tests, coagulation tests, aPTT or the prothrombin time are very sensitive. No, it depends upon what is the concentration of the factors, deficient factor. And there are different levels to which a coagulation factor has to be decreased before the screening test can pick up the abnormality. Now, most of the commercial aPTT reagents, they detect a decrease in factor 8 when the level is down below 35 to 45%. Remember, the normal value of factor 8 is 50 to 150%. Likewise, the factor 12 deficiency or the high molecular weight kinogen need to be decreased below 10 to 15% before it can manifest as abnormal aPTT. Factor 7 has to be decreased below 35 to 40% before it can be detected by PT. Therefore, remember, in clinical practice, many times normal aPTT or prothrombin time does not rule out mild deficiency of the disease. Now, prothrombin time, coming to the next coagulation test, which is the prothrombin time. It is used as a measure of the extrinsic pathway and the common pathway. And again, traditionally, what the manufacturers previously were using the tissue thromboplastin, which was derived from the animal brain. But nowadays, recombinant tissue factor is available, to which phospholipids have been added. And because of this assay has become more sensitive. And because the range of prolongation of time of abnormal PT has increased when you use a recombinant tissue factor. Now, to test this coagulation test, that is the prothrombin time, the tissue, that is the recombinant one, and the patient plasma are incubated, to which calcium is added. And the normal range of prothrombin time is usually 11 to 16 seconds. Now, I'll come to the concept of INR later in my subsequent slides. Now, what are they? I've told you that the prothrombin time, it reflects the extrinsic pathway and the common pathway. And therefore, if the PT is prolonged, then it is because of the factor 7 deficiency, because of vitamin K deficiency, because the 4 factors are 2, 5, 7. They are the vitamin K dependent. Then the warfarin therapy or malabsorption, especially the vitamin K dependent coagulation factors, liver disease and DIC, and of course, the presence of lupus anticoagulant, though it is less common as compared to prolongation of aPTT. Now, the results of, previously, before the concept of INR came, the laboratory reports of prothrombin time used to vary from one lab to another because of the type of analytical system which was employed. And because all these laboratories were using different batches of tissue factors, which were, and therefore, there was a wide variation as far as the value of PT. In order to standardize the PT value, and therefore the concept of INR came into existence. And this is calculated from prothrombin time, and is intended to make the comparison similar regardless of the PT reagent which is used among different laboratories. Now, INR is calculated by this formula, and this is the International Sensitivity Index, which is the measure of the sensitivity of the particular prothrombin reagent. And this is determined by the manufacturer. And the value of ISI is usually between 1 to 2. Now, by this formula, the variability among the prothrombin reports between the different labs has now become less and has become more standardized. And therefore, whenever you're ordering for prothrombin test, always ask the value in terms of INR. Now, the normal in healthy person, the value of INR is 0.9 to 1.3. And patients who are on warfarin therapy, usually the therapeutic window is that we keep INR between 2 and 3. If the INR increases more than 5, it means there's a high chance of bleeding. If it is less than 0.5, there's a high chances of thrombotic events. There are certain situations where we keep the INR about 3, which is between 3 and 4, when you require a supratherapeutic level of warfarin. And these are the conditions who have repeated thrombotic or thromboembolic episodes, even in the presence of mechanical heart valve, or because as a bridging warfarin with low molecular weight heparin when the patient is taken for surgery. Now, INR monitoring, I told you, is very essential for all patients who are on oral anti-vitamin K antagonist, that is the warfarin and acetrom. And the importance is to keep the INR within the therapeutic range. And of course, the therapeutic range is quite narrow, between 2 and 3. I've already told you, if it is less or it is more, can lead to either thromboembolic event or could lead to excessive bleeding. Now, this diagram shows that what is the therapeutic window when you are assessing the warfarin therapy or acetrom therapy. The INR is the therapeutic range is between 2 and 3. On either if it is less, it leads to thromboembolic events or hemorrhagic events if it is more. Now, with the bleeding, chances of bleeding with warfarin is greatest when you start in a patient who has not received previously the warfarin or during the first 3 months of treatment. And therefore, every physician and the PG trainee should be aware the risk which is involved when you initiate anticoagulation with warfarin. And so once the INR is stable, then the INR testing can be extended to 2 weekly and then to 1 monthly. But previously, initially, it has to be repeated more frequently, maybe twice initially, twice a week to weekly, before the INR is stabilized, because of the chances of bleeding, which is very more often during the first 3 months, and especially if the patient has not received warfarin previously. Now, coming to the role of liver disease in bleeding disorders, we know that the liver produces all the coagulation factors except factor 8, which is produced from the endothelial cells, and the factor 13, that is the fibrin stabilizing factor, which is produced from the megakaryocytes. So in patients who have alcoholic liver disease, especially who are drinking alcohol actively, and there's a concomitant vitamin K deficiency, can further exacerbate the deficiencies of vitamin K dependent factors, which are mainly 2, 7, 9, and 10. And therefore, remember, vitamin K deficiency or chronic liver disease, where the synthetic functions of the liver is compromised, can lead to increase in the prolongation of prothrombin time. Now, what are the test variables which can affect the prothrombin time in aPTT? So what I was talking about the pre-analytical variables, there are 4 important variables which one should always remember while evaluating a patient with prolonged PT or aPTT. These four conditions are: what is the hematocrit or PCE for the patient? What is the concentration of the sodium citrate anticoagulant? Is the patient in fasting state or not? That is, whether the patient sample was drawn post-meal or in the fasting state. And what is the time interval between the sample collection and the performance of the test? These four factors, they are very important for proper assessment of the prothrombin time and partial thromboplastin time. Now coming to factor one, that is the hematocrit. Now on the left view, what you can see, this is the normal hematocrit between 35 to 55. So you have a plasma is there, hematocrit is normal, and this is the oral anticoagulant. The ratio of citrate to the plasma should be to the tune of 1:5. When you collect the blood, it is 1:9. That is, the blood is 9 and the citrate anticoagulant is 1. So when you the plasma is generated, the ratio should be 1:5. Then it will give you the accurate assessment of the prothrombin time. But in case a patient has high hematocrit, maybe more than 55%, what will happen? The ratio of the citrate anticoagulant and plasma is no longer 1:5. It is around 1:3. And this will lead to what happened? There is the spurious prolongation or in the prothrombin time or the partial thromboplastin time. And so what I've told you is the second important factor, what should be the concentration of the citrate? It should be 3.2%. The volume should be 9 volume blood to 1 volume anticoagulant or 5 volume of plasma to 1 volume. Now, if the hematocrit is abnormal, either below 35 or more than 55, this is the formula to reach the ratio between the citrate and the blood. So if it is 20%, you use only 0.7% ml of citrate and the blood should be 4.3. And likewise, if the hematocrit is 70%, only 0.25 of citrate and 4.75 ml of blood is to be used. Then only the correct value will be obtained. So when I just remember that whenever you're ordering for prothrombin time or partial thromboplastin time, please take note of the hematocrit value of the patient. And I've already talked about the fasting state. Then important, what is the time interval between the collection and performing the test? Now, PT can be performed up to 24 hours at room temperature. But aPT should always be run within 24 hours because the factor 8, which is part of the intrinsic pathway, that is the aPTT pathway, is very labile. So in case it is not possible to do, the plasma should be separated and should be deep freezed. Always use plastic tubes, no siliconized plastic tubes or no glass tubes. So the clinicians and the PG attendees, students, whenever they are ordering for prothrombin time or partial thromboplastin time, should see that the patient is in fasting state and should inform the lab in the requisition, that is, what is the hematocrit value. If the hematocrit value is less than 35 or more than 55, it should be duly informed to the pathologist and technician. Then only you can get a correct report. Now, whenever you have a patient who comes with prolonged PT or aPTT or both are prolonged, how to proceed further? It is very important. And there are certain questions one should always ask in your mind, how to proceed further. Now, the first question is the prothrombin time or aPTT artifactually prolonged? So I have already enumerated that 4 pre-analytical factors which can artificially can prolong PT or aPTT. That is the concentration of the coagulant, the ratio of blood to the anticoagulant, time interval between the collection and the performing the test, and is the patient in fasting state or it is the blood is collected post-meal. So this is most important when you proceed towards the cause of prolonged PT or aPTT. Second important thing is the patient receiving, always ask in the history, is he receiving oral anticoagulants, vitamin K antagonists? Is he receiving heparin? Is he receiving the newer anticoagulants, that is the directly acting oral anticoagulants? Is very important because they also interfere with these coagulation tests. Then third is the one should always evaluate history-wise and otherwise by clinical examination. Does the patient has chronic liver disease? Does the patient have connective tissue disorder, or is the patient is in a state of DIC? Because all these conditions, you have prolonged PT and APT. And therefore, clinical evaluation that includes history, one should always look for systemic disease. Then once you are satisfied that these first three questions are optimally answered, then how should we pursue further? Then one should always ask for mixing studies, because I'll tell you what is the concept for mixing studies, because it will help you whether there is a deficiency of factor or is the presence of inhibitors. And this mixing study should, with normal plasma, how should we interpret? Do we have a factor deficiency is causing bleeding disorder, or it is due to the presence of inhibitors? And the most common inhibitor, what we see in clinical practice, is the lupus anticoagulant. Now, what is a mixing study? Basically, when you have unexplained prolongation of PT or PTT or both, you perform a mixing study. That is, you add half and half of plasma with the patient's plasma with the normal plasma. Now, if the coagulation, this test is corrected, it means there's a deficiency of factor. If there is no correction of PT or PT, it means there's a presence of inhibitor. Now, remember, whenever you are performing mixing study, usually all pathology technicians, they treat the blood sample with heparinase, with degraded heparin. Now, if the prothrombin time and PTT, if corrects with heparinase, then of course you do not have to do even a mixing study. So the first step for the pathologists and the technicians who are on doing coagulation tests, that if they have requisition for that, go for the mixing study, they always first perform the test by adding heparinase. And if the PT-APT remains uncorrected, that is, remains unprolonged, then only the mixing study should be done. I think that concept is very, very important. Now, what are these coagulation factors? Now, these are also known as circulating anticoagulants, and because they interfere with the blood coagulation, they are usually the IgM or IgG isotype. They can be present congenitally or they can be present acquired. And then the most common I have told you is the lupus anticoagulant inhibitors. Otherwise, you can have antibodies which are specifically against factor VIII. These are the conditions either the patient has hemophilia with high titers of antibodies, or patient because of some other reason can have acquired hemophilia where the antibodies develop against factor VIII. Now, lupus anticoagulant, what I've told you, the commonest lupus inhibitor, coagulation inhibitor, which is we see in clinical practice. Again, it is also known as antiphospholipid antibody because it is directed against the IgG antibodies of the phospholipids. And it is usually prolongs the aPTT and the clotting time. And now, what's the difference between this inhibitor and the factor-specific inhibitors? When you have factor-specific inhibitors, say against factor VIII, then it causes what you call bleeding disorder. But the presence of lupus anticoagulant does not cause bleeding. It causes thrombosis and abnormal clotting. And therefore, the term lupus anticoagulant is a misnomer. It does not cause a bleeding disorder. In fact, it causes thrombosis. And it is very important to understand because of its the actual nomenclature is a misnomer. Now, how do you approach when a patient has prolonged aPTT or PT, or it is both? It's very important that how should we proceed further. Now, I have already discussed that when the aPTT is prolonged and the PT is normal, you think in factors of 12, PK deficiency or high molecular weight kininogens. Of course, I've told you these are prolonged. PTT is prolonged if there's a deficiency, but there is no clinical bleeding. And therefore, whenever you are assessing patients with bleeding disorder with prolonged aPTT, never think in terms of these three factors. Even if they are deficient, they never cause clinical bleeding. one should think of the hemophilia that is the factor 8, 9, or 11 deficiency. In some cases, von Willebrand disease, and the acquired causes I've told you already discussed, DIC liver disease, or patient is on oral anticoagulant, or patient is on heparin, or the blood sample has been drawn from a line which is heparinized, and therefore there is a contamination with heparin. Now, if on the mixing study, if there is no correction, that means that there's an inhibitor is present, and usually I've told you it is the lupus anticoagulant. I'll not just go into it more details. So the situation is for the aPTT is, so when you have do a mixing study, 1:1 mix of patient and normal plasma, and if normalized, it means there is a deficiency of factor. If there's a mixing with normal plasma and the partial thromboplastin time initially shortens and then subsequently prolongs, it means there's the presence of factor 8 inhibitor. And if after mixing the PTT remains permanently prolonged, it means inhibitor is present, and the most common is the lupus anticoagulant. Now coming to the prolonged PT, when the aPTT is normal, it could be deficiency of a common pathway or factor 7. It could be also because of prolonged antibiotic use, which can lead to vitamin K deficiency. And the vitamin K deficiency factors are 2, 5, 7, and 9. And we know that the factor 7 is the rate limiting step as far as the prothrombin time is concerned. Of course, and less commonly, one can see deficiency of factor 5 in liver disease or myeloproliferative neoplasms, or there could be less common condition. There's a deficiency of factor 10, which is seen in amyloidosis. So whenever you are making an interpretation of prothrombin time after mixing study, if it normalizes, it again shows the deficiency of these factors. If initially it shortens and subsequently prolongs, it means there is a inhibitor to the presence of factor 5, which is part of the common pathway. It is very rare. And if the PT remains prolonged after mixing with normal plasma, it means presence of specific inhibitors. And these could be factor inhibitors, and lupus anticoagulant is less common, which interferes with the prothrombin time. So this is the very congested slide. Of course, it shows the various combinations where either PT or PTT is prolonged or both are prolonged. And of course, I've already discussed these parameters. I think, let me do the slide now. Now, what are the points one should always remember when you are taking? And so whenever, if you are doing aPTT and the patient has heparin, just collect the sample at least 1 hour before the heparin injection. With low molecular weight heparin, there is monitoring really not required, though there is a slight increase in aPTT. Now, with warfarin therapy, PT is prolonged, and there could be a mild prolongation of aPTT because, again, because it's a vitamin K antagonist and factor 9, which is part of the aPTT cascade, can be diminished in patients with warfarin therapy and therefore may be mild. But in clinical practice, whenever patient is on warfarin therapy, we monitor the therapeutic range only with prothrombin time. When you are using unfractionated heparin during the cardio bypass surgery, usually the aPTT is prolonged and not the PT. And just make sure that how you are collecting the sample, it is from the arterial line. Is there any contamination of the heparin when you are using heparin lock to keep it, or before collecting, you should flush the indwelling catheter with saline. So these are very important things one should always remember. And remember that at times, what I've told you, that the warfarin, usually we test the prothrombin time, but if you are using high levels of prothrombin time to achieve supratherapeutic levels, then even it can prolong the aPTT. And similarly, heparin, though it typically prolongs the aPTT, but at high levels, again, it can prolong prothrombin time also. Now, the direct thrombin inhibitors, usually we do not monitor these neuroanticoagulants with the prothrombin time or activated partial thromboplastin time. But theoretically, they do prolong both the test, and but at low levels, the dabigatran may not prolong the prothrombin time, and the direct thrombin factor 10 inhibitors, they prolong both PT as well as. But I've told you that whenever you are using the newer oral anticoagulants, this could be direct thrombin inhibitors or direct factor A inhibitors. Usually, we do not assess the what you call the coagulation profile with PT or aPTT. Then now let's I'll just discuss three cases. Case one, of course, actually my slides are not visible because of yeah. This is case one, 26-year-old male. He presented with 2 episodes of mild epistaxis in the past 2 days. He also gave a history of occasional completes while brushing the teeth. Now, he gave a history of fever 1 week back for which he had taken some medications. Platelet, when we have investigated, platelets turned out to be normal. The prothrombin time was normal. Bleeding time, of course, in this case was normal. Partial thromboplastin time was raised. It was to the tune of 52 seconds. Thrombin time was done. A mixing study was done. And this patient again showed that the mixing study, the aPTT came down to 36, that is normalized, and factor 8 was decreased 30 to the unit 30 units per deciliter. And we're now suspecting patient has some bleeding disorder. So it was further investigated. Factor 9 was normal. Von Willebrand assay was done. It was decreased. And the platelet aggregation cystosin was done, which showed abnormal aggregation. And just remember, this was a case of von Willebrand disease. Now we know that the von Willebrand factor is the carrier protein for factor A. So when it is deficient, so the factor assay would be 8 would be less, and the PT would be prolonged, but on mixing it normalizes. So this is a case, and this patient, if you see the history here, is a mild bleeder. So the commonest cause of mild bleeder is the von Willebrand disease. Now this is a case of a 2-year-old boy who was brought to ER with severe bleeding into the joints, following a very trivial fall. His family history of bleeding disorder was very significant. Maternal grandfather died of brain hemorrhage. Uncle died of, again, hemorrhage following an accident. His mother and sisters were normal. This patient had prolonged partial thromboplastin time. When the mixing study was done, it came to normal, within the normal. And therefore, thinking that evaluating the concentration of the factor, the commonest is the factor 8, and it turned out to be only 8 units. And this was a case with normal von Willebrand assay and platelet functions. So this was a case of hemophilia A, factor 8 deficiency. Now, this is the third case, a 28-year-old lady. She presented with recurrent spontaneous abortions. She was investigated by the gynecologist, and what was seen was the partial thromboplastin again was raised 53, and on mixing study it did not correct, and factor 8 was normal. And of course, the von Willebrand assays and platelet functions were normal. The dilute Russell Viper venom test, which was done, it was abnormal. And this was a patient who had the lupus anticoagulant. So the first case was a classical case of von Willebrand disease. Second, hemophilia A, and the third, a lupus anticoagulant. And probably this patient, if you go to the history of spontaneous abortions, and as I already discussed in my previous lecture, the criteria for diagnosis or antiphospholipid syndrome. So this was a patient with antiphospholipid syndrome, which was secondary in nature because of lupus erythematosus. So to sum up, prolongation of these bleeding coagulation test, that is PT or aPTT, should always be correlated with the patient clinical history. What is the bleeding history, and the medication history is very important. And at times, what I've told you, the 4 pre-test variables should always be kept in mind before labeling that the coagulation tests are truly prolonged. And further testing should only be assessed and done only when you cannot explain prolongation of PT or PTD, either because of the pre-test variables or because of the patient is taking some medication or on heparin or anticoagulant therapy. Now remember, usually in clinical practice, we do not monitor coagulation with when you're using low molecular weight heparin or the new anticoagulants. And for the proper interpretation of prothrombin time and partial thromboplastin time, it is very important, especially the PG residents, they should provide all the clinical information as far as the bleeding disorder, the medications, and what the patient, and of course, especially the hematocrit value and the time when the patient sample was drawn and the amount of blood which has been properly drawn in proper ratio or not. The clinician and the resident should always liaise with the technician and the pathologist if you want to have a true picture of prothrombin time and the activated partial thromboplastin time. So with this, I conclude my lecture. Thank you very much for your patient listening.
Sir, can you just open 48 number slide, sir? It has been missed, sir.
48. Okay, yeah, I did not take this slide. This is the expected. Now, what are the effects of anticoagulants on these tests? So if patient is on vitamin K antagonist 2, what we are using, the warfarin and acetrom, so the PT is prolonged. This may be prolonged aPT only when you're using high dosage of warfarin or the acetrom. When you are heparin, if you are using unfractionated, of course, the aPTT is prolonged. And of course, heparin, because it is an anti-factor 8, so it is also prolonged. Same with low molecular weight heparin. With direct thrombin inhibitors, that is the most common what you use is abicatran. Of course, both are prolonged. Same is with the direct factor 10 inhibitors, that is the rivaroxaban and ixaban. Both may be prolonged, but usually we do not perform these tests with these neo anticoagulants. Is it okay now?
Yes, sir. Thank you, sir.
Just in any chat box, are there any questions? Dr. Daria? What I mean, there's no questions from the audience. I know for many it would be a boring, but it's a very important subject because as physicians and as trainee residents, we are often asked to give clearance, surgical clearance to the patient for the surgery. And bleeding disorder is very important. They usually come with only prothrombin time. And usually this is the trend in major hospitals, what I've seen in my professional life. And I always emphasize that PT alone will not give you the full picture of bleeding disorder in any patient who is posted for surgery. It's very important, in fact, to assess the activated partial thromboplastin time because hemophilia is more common than you have the prolongation of PT, because prolongation of PT, the commonest cause what you see is either DIC or chronic liver disease, or patient is have vitamin K deficiency. But more bleeding disorder cases, they come up when you evaluate patients with the aPTT cascade. So important that whenever you're asking the patient, evaluating a patient, always order for both PT and aPTT. Clotting time is obsolete, archived. You do not have to do it because you're already doing PT and aPTT, which are very sensitive assays. And for hematologists, bleeding time has no clinical relevance. In fact, taking a good bleeding history is much more important, of more value than doing a bleeding time.
Sir, what is the dose of vitamin K to be given in vitamin K deficiency, sir, to correct PT?
It depends how much the deficiency and how the patient is bleeding. Usually what we do is the one vial which contains it contains around actually I do not remember, that is one vial contains around 5 milligrams or so, that has to be given. Remember, never give intramuscular. It has to be given IV, because in a patient who is bleeding, if you do intramuscular shot, then what you are producing a big luteal hematoma.
Sir, while monitoring PT in a patient with snake bite, sir, how much time we have to wait after giving ASV, sir, to check for the next PT?
No. There's no role of doing no correlation between anti-snake venom and doing a PT. If you suspect that patient has bleeding is, of course, that is the so-called DIC or defibrillation syndrome. You immediately have to look for the very important test. Of course, I don't discuss there, they're not part of my lecture, is monitor the platelets every 4 hourly, 6 hourly. In every DIC, there would be reduction in the platelet count over a 12-hour period. So PT and aPTT will take some time to generate. Just do platelet counting every 2 hourly, 4 hourly. So by the evening, if you see the platelets has from 2.5 lakhs has come down to only 50,000 and patient is bleeding, then you are almost 100% sure that patient had DIC or defibrillation syndrome. And then when you get the report of prothrombin time and aPTT, both would be markedly prolonged. So this is how you assess, in fact, clinically, because in many ways, centers where you do not have facility for doing coagulation test, or you have to send the sample to other laboratories, simply doing serial platelet counting on the same day, if you suspect that this patient has now bleeding, has defibrillation syndrome, even subclinical defibrillation or DIC, then this is a very simple test, because there's no DIC without which DIC can never account with a normal platelet count. This is a clinical dictum actually.
Sir, under small doubt, sir. You have told now, sir, while doing the mixing studies, if it initially falls and then it is prolonged,
Then it
then
is,
the probate inhibitors. How
yes,
much time we have to take, sir? That initial drop and next
it is
prolongation.
what, of course, I'm not a pathologist, but I think it's around 2 hours. I think the 2 hours, this is what we wait for 2 hours for the lupus anticoagulant. Because I never worked in the lab, but when I created my advanced rheumatology lab and Cog lab in that semester around 14 years back. So around 2 hours before the pathology reports, is it because of persistent prolongation or there is a temporary normalization followed by the prolongation? That is because of the specific factor deficiency. With inhibitors, it remains prolonged after mixing.
Thank you so much, sir.
I think who was the gentleman who was asking these questions? I think please identify yourself. You are
Sir, my name is Dr. Sai Tejas, sir. I have completed MD General Medicine now, sir.
okay. From where?
Recently. From Rangaraya Medical College, Kakinada, sir. Andhra Pradesh, sir.
Okay. Now what you are pursuing, doing?
Senior residence in SWIMS Tirupati, sir.
Okay. Okay. I think I have hopefully I have
Yes, sir.
answered your questions.
Yes, sir. Yes, sir. Yes, sir. Thank you so much, sir.
Any questions? Any queries? Dr. Daria? Dr. Daria? I think probably not there. Anand, are you there?
Sir, in chat box, one question, sir. That is PT and aPTT in DIC, sir.
Both are prolonged. Both, because it's absolute defibrillation syndrome. No? So this was one of the, I'll tell you I skipped one of the slides because this one of the slides I think I'd shown you. I think I missed. Is it this slide? Okay, okay. So when you have a prolonged PT and aPTT, so acquired is DIC, liver disease. We had already discussed when I was discussing the individual, therefore I did not take up this slide. And so if for all, just a very short revision. So when you have a prolonged PT with normal aPTT, you think in terms of factor 7 deficiency, mild vitamin K deficiency, liver disease, or patient is warfarin, and DIC, of course. And when you have a patient with abnormal aPTT with normal PT, you think in terms of inherited deficiency of factors, that is hemophilia A, B, or C, or you deficiency of these factors. Of course, these factors are not associated with clinical bleeding or with von Willebrand disease. Of course, the prolongation of PTT is variable depending upon the one bilirubin assay. And then you have the acquired causes. When both are prolonged, inherited, this means the deficiency of the factor 2, factor 1, factor 5, that is the deficiency of the common pathway coagulation factors, 5, 10, 1, and 2. Or you have combined factor deficiency, or the acquired ones would be the liver disease, DIC, CO vitamin K deficiency, or when you're using high doses of anticoagulants or combining oral anticoagulants with heparin, or patient has amyloidosis. Of course, it is a rare disease, amyloidosis associated factor 10 deficiencies, or you have the acquired inhibitor of factor 7. Again, it is a rare disease. So this table is summarizes the various combination and combinations of PT and aPTT tests. I think if the moderator, I don't, Dr. Deri, I think he is somewhere busy, must be taking the class, because this is the time for taking the classes of the undergraduates. Anand, I think if there are no questions, can we close? Even Anand is, of course, is not. So if there are no questions, can we close the attendees? I think.
Yes, sir. Yes,
Yes.
sir. Thank you
Yeah.
so much, sir.
Yeah, thank you very much. I hope most of them must be sleeping with this topic, but it's very essential for physicians and PG residents. Okay, thank you very much.